We have Anushree NAIDU. She's available here, and she's going to talk to us on a spontaneous closure of a large traumatic macular hole, neurosensory detachment of retina.
Good morning, everyone. Spontaneous closure of a large traumatic macular hole with neurosensory detachment of retina. Macular hole is a vitreoretinal interface disease characterized by partial thickness or full thickness neurosensory defect of the center of macula. Causes of macular holes can be idiopathic, high myopia, trauma, or certain eye disorders like retinal detachment, epiretinal membrane, diabetic retinopathy, etc. A traumatic macular hole is a full thickness retinal defect at the fovea, typically resulting from blunt trauma. The treatment includes observation for spontaneous closures or vitrectomy surgery with ILM flap or peel, gas or a silicone oil injection. We report a case of spontaneous closure of a large traumatic macular hole with neurosensory detachment of retina along with a gradual remodeling of the retinal layers as depicted on serial OCT scans in a 37-year-old male over a period of 6 weeks. A 37-year-old male presented to me with a history of trauma to his left eye following a fall. The BCVA recorded in right eye was 6/6 and N6, and left eye he had a hand movement vision with no improvement. The anterior segment examination he had ecchymosis, chemosis in the left eye, and a retina examination revealed a large traumatic macular hole with the neurosensory detachment of the retina, as we can see on our OCT scan and the color fundus photograph. I did a conservative management for this patient with topical and oral NSAIDs and steroids. As we can see, just after 2 days, the OCT showed near total resolution of neurosensory detachment in this case. And as we can see, there is a centripetal migration of the cells towards the fovea. In the 6 days after the conservative management, the patient had macular hole was completely closed anatomically with the continuity of ELM and partial resolution of the ellipsoid zone. Then after 3 weeks, the patient had a more better picture with total resolution of the neurosensory detachment, and as we can see, the outer retinal bands remain mildly irregular, suggesting an ongoing photoreceptor alignment and recovery of the photoreceptor RPE junction. This is the course of the treatment. This was a presentation. Patient has the BCVA of hand movement, and on day 2 and day 3, he developed a BCVA of 2/60. And after the resolution of the macular hole, his visual improvement was 6/36, no improvement. And I did serial OCTs over 3 months, and as we can see later on, he developed some RP hypertrophy in their later OCT scans. But his vision improved to 6/36 and it remained stable thereafter. So traumatic macular hole is an uncommon complication of blunt ocular trauma. It can occur because of immediate and direct foveal dehiscence or vitreomacular traction. Spontaneous closure of traumatic macular hole has been documented, making observation a reasonable initial management strategy. There are certain favorable prognostic factors like Mitamura et al. Suggested that younger age, smaller hole diameter and presence of posterior vitreous detachment are the factors associated with spontaneous traumatic macular hole closure. The mechanisms of hole closure include glial cell proliferation, formation of an epiretinal membrane, and reattachment of the hole through the operculum formation. An alternative hypothesis involves bridging of the macular hole by proliferating retinal tissue. To conclude, I would like to say that in my case, the remodeling was occurring over a period of 6 weeks, and using oral steroids was an effective strategy. The glial cell proliferation was the potential mechanism in this case, and I believe that observation is a better initial strategy and it avoids unnecessary surgical risks. Thank you.
Very nice. I was wondering whether it's neurosensory detachment or the PVD which became complete and the hole closed.
So the patient had
because you see that the entire retina has been lifted up. Was there any vitreomacular traction at that time?
So the patient had presented just immediately the next day. On presentation, the patient had complete like PVD. Along with that, there was a traumatic large hole, and along with that, there was the fluid which was going posteriorly from the hole.
So you said conservative treatment. So what did you give any treatment or just observe?
So I gave him oral steroids and topical NSAIDs and steroids further.
Do you think steroid had any role in
So
healing?
there are certain studies which have suggested the role of steroids in closure of macular holes. And even after the re-surgery also, even after the normal macular hole surgery also, if there is a recurrence of hole, the certain studies from Canada and USA now say that topical steroids also are effective in re-closure of the hole without the surgery.
How long was the follow-up?
So I followed up the patient for now almost 6 months, and after that he didn't come for follow. Now I call him at 6 months.
No, was there any Berlin's edema at that time? Because if you look at the picture there, and also the OCT does not appear to be full thickness. If you go back on the.
They have changed the presentation.
Can you have the slides again, please? Show the fundus picture. It's a blunt trauma, no? It's a blunt trauma. Whether there any Berlin's edema was there and
there was
that got settled down.
Full thickness hole of the macula.
No edema.
No, there was bare minimum edema for this patient.
Yeah, that's what I'm telling. Yeah, and also I feel is it in the macula, slightly parafoveal?
So
if you see the photo, the macula, yes, it's slightly wide. The macula is slightly on top, superior. See, there is some white spot there, no?
Yeah.
So whether there is some sort of edema there, Berlin's edema. I'm wondering whether it's a true macular hole or something different.
But it is separated anyhow.
Yes, sir. I have a doubt whether it's a pseudo-macular hole or... Because it's not in the... If you look at the... Where's the macula in that? Can you show it in the with your... Yeah. No. Because macula is straight. You have to see, macula is not higher level than the disc. No, I'm talking about the fovea. So okay, not the macula. Macular is a bigger area. If you take the fovea, it's straight from the disc it has to come, no? Thoda upar hai. You got the point. And you are taking the scan right there. It's parafoveal actually, because the fovea is got macular, the Berlin's edema there. What you see whitish area, just slightly above that is the fovea. Can you just put the arrow there? No, this side, on the picture, on the fundus picture.
Yeah. Here.
Yeah, that is yeah. No, the white spot is there. No, white spot next to it. Yes, that's a Berlin's edema probably. Look, slightly put the arrow up. Slightly to the right, that will be the that will be the fovea. Slightly to the left. Slightly to the left. Yes, correct. No, you put it there. Slightly to the left. To the left. Left, ma. Yes. Somewhere there will be the fovea. So I was wondering whether we are missing something else there.
Did you do multiple scans?
Yes, the multiple scans were done. Like when the Rhine and the raster both were done.
That would show whether it is macula.
So it was involving the entire region only. It was slight parafoveal in appearance, but it was a complete hole, full thickness hole.
Okay.
Because you said because I don't see the PVD also there. Because otherwise in OCT you should be able to see the PVD there, full PVD. Whereas any other scan is able to pick it up. So we have to see the serial scans.
So these were
whether there is some sort of traction on the macular hole, on the inner retina by the vitreous, and when there is a spontaneous, when the injury occurs, no, so this spontaneous PVD could have occurred, and the hole would have, and the entire retina would have gone back, and hole closed. That's my presumption of this. Anyway, it's a good thing. Thank you very much for that. Any questions from the audience? Okay, thank you.